The first, by presenting him the cotton threads. Over to Dr. Samir Kapadia.
So, first of all, thank you very much. I know we are running a little bit late, so I'll try to compensate for some time. I'm thankful to Dr. Nissan and all the dignitaries who are here, and also thank Dr. Tuju and Nissan for coming from such a long distance for the conference. What I'm going to talk about is a little bit technical, but I'll try to make it as simple as possible. It is to say that all the patients with acute coronary syndrome, meaning the patients who are having chest pain, do they require cardiac catheterization or not? That is the question that is asked. So the first part that I'm going to discuss is to try to understand that what is the acute coronary syndrome. So if you look at the acute coronary syndrome, there are two parts to acute coronary syndrome. One is, of course, ST elevation MI. ST elevation MI is the acute myocardial infarction. Somebody is having acute MI. When you have the acute MI, then there is no question you need right away reperfusion, meaning that you need to have coronary angiogram, angioplasty, or thrombolytic therapy right away. So there is no question in that group of patients whether there is invasive treatment needed or not. So now we are talking about non-ST elevation MI. So if you look at the non-ST elevation MI, there is unstable angina, and then there is a non-ST elevation MI. So unstable angina is the patients who do not have myocardial injury. And non-ST elevation MI are the patients who have myocardial injury, meaning that there is high troponins, CKMB, in the blood. So we are going to talk about all these different points in next 20 minutes or so. Pathophysiology-wise, what is the difference between ST elevation MI and non-ST elevation MI? Is that you have a plaque. Plaque may have ruptured, may have formed a clot, many times the platelet-related clots, but the clot is not occlusive, meaning the artery is still open, the intrinsic fibrinolytic is working, it is generating increased fibrinolysis of your own clot, it is generating thrombin, and the platelets are being activated, and platelets are occluding the artery. So the artery is subtotally occluded, and the antiplatelet agents are the main group of pharmacological therapy that you will use in these patients. So there are a lot of different things, and I will, in the interest of time, skip this particular part, that some evidence to say that the plaques rupture in more than one place at the same time in significant number of patients. In this particular study that we did, we found 19% of the patients had a plaque rupture in more than one place at the same time. So what is the most important part of the therapy, that which patients require a invasive therapy right away versus which patient? So you cannot keep the patient at home. Patient has to be not in the emergency room. Patient, if you're suspecting unstable angina, has to be admitted to the hospital. Continuous clinical assessment is necessary. ECG and marker data are necessary. And then if you say that I'll show you, which are class 2A or B evidence, class 2A meaning that it is sometimes helpful, but it is not conclusively helpful in this particular group of patients. So if you take the patients who have the adverse, who have chest pain that you think is from coronary artery disease, then the second question you're going to ask is that, is this patient going to die, is going to have a large myocardial infarction or heart failure? So that is the consequence, that is the outcome. So first you are going to try to determine if this patient really has coronary artery disease, and if you think that is coronary artery disease, what is the likelihood of having bad outcomes? So these are the two very important parts to understand. So very simple thing, ECG, if you have T-wave inversion, your outcomes are the best, but if you have ST depression or ST elevation, your outcomes are really bad. So if you have new ST depression, it is as bad as having new ST elevations. So you remember that if you have ECG changes with ST depression, this is a high-risk situation, where if you have just T-wave inversion, these patients do typically better than patients with ST depression. Troponins, if you have more than one, this is the classic troponin. This is not high-sensitivity troponin. Troponin I, if it's more than one, your risk is 3 times higher than if it is less than 0.4. So if the troponins are increased, that means you are identifying high-risk patient. There is a myocardial injury that is happening. And there is a TIMI risk score. This is a risk score that is available with the TIMI calculator, with the tactics trial, 2,000 patients looking at risk factors to say that which patients are at high risk. And if you are more than 65, if you have more than 3 coronary artery disease risk factors, or you have known coronary artery disease, or you are taking aspirin, so you are already taking aspirin and breakthrough chest pain. If you have more than 2 angina episodes in the prior 24 hours, or you have ST abnormalities, as I said, or enzymes are positive, these are high-risk patients. And if you have TIMI risk score, which is 3 or more, this is considered a high-risk patient. So if you look at the guidelines, it says that you have to perform the ECG in 10 minutes, you have to look at you have to draw the troponins, and you have to do serial enzyme assessment for these patients. Risk stratification then is very important. BNP is plus minus, is class 2B indication. And if you have patients who are having chest pain and you suspect that this is posterior wall myocardial infarction, you may want to do right-sided or posterior ECGs, and that is what is saying as class 2A indication. Now, which patients require early invasive treatment or invasive treatment? And then you do a cardiac catheterization in some patients, and other patients you do not do cardiac catheterization and continue the medical treatment, whereas the patients that you do cardiac catheterization, then you do invasive management, either with a PCI, CABG, or in some patients still medical management. So these 2 groups of patients you are going to manage a little bit differently with terms of anticoagulation or not. So if you are having the acute coronary syndrome, if you take all the trials of invasive versus initial conservative trials, there is a small mortality benefit. But as you see, if you look at all the trials, the confidence interval crosses the unity, meaning the trials are more or less not significant or borderline significant. So there are some patients in all these trials that may be benefiting more, others are not benefiting as much. That is the concept that you are going to understand. So if you do the meta-analysis to look at unstable angina or repeat rehospitalization, again, you see a benefit of early invasive strategy. Now, if you look at this ICTUS trial, this is one of the trials that followed 1,200 patients long-term, 4-year follow-up. And if you look at the red is the early invasive, and the blue is the selective revascularization. Selective meaning that you're selecting patients that you think are not needing early revascularization. You can see all the outcomes, death, spontaneous MI, cardiovascular death, similar. So you can potentially select appropriate patients. 40% of the patients can potentially be managed without intervention in this group of patients. And now the concept that I was trying to tell you is that if you look at the death, MI, and stroke rate, no difference. But if you add to it the refractory ischemia, need for repeat revascularization, then obviously it changes to a statistical significance. TMAX trial is another very important trial to understand that if you take the patients, about 3,000 patients, and now the grayscale, again, in serial ECGs, troponins, their outcomes with conservative treatment versus aggressive treatment are very similar, 7.7 versus 6.7%. But if you take the high-risk patients, obviously different. So again, trying to understand that who is at high risk with ACS is a very important part of decision-making, that who requires early versus delayed revascularization. And this is the list of things, and I can read it again, but I kind of highlighted most of them. High-risk features. These are all high-risk features. And if you have these patients with recurrent angina, heart failure, hemodynamic instability, VT, recent PCI, high TIMI or gray score, diabetes, decreased ejection fraction. This decreased ejection fraction is very important. So if your EF is less than 40 and if you are having unstable angina, these are the patients that are also considered extremely high risk, and you have to do intervention. So again, this is the guideline which is again stressing the importance of low ejection fraction. Now, what are the antiplatelet therapies? Of course, aspirin is the key, and there are some trials looking at the aspirin. Now, aspirin is so proved to be important in unstable angina that no more recent trials looking at aspirin versus placebo. How about dual antiplatelet therapy? Clopidogrel versus aspirin. And if you take the dual antiplatelet therapy, the outcomes are better. This is the CURE trial. These are not very high-risk patients, but still in that trial also,